Good evening, everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this fifth episode of Nephro Live. And today we are going to discuss about very critical and one of the most challenging clinical topic, that is acute kidney injury, prevention and management strategy. And to guide us, let me help in welcoming our course director, Dr. Kullar. Dr. Kullar needs no introduction as he has been instrumental in shaping and steering insightful and impactful discussion throughout our previous episodes. However, as a customary, I would like to introduce him to acknowledge his leadership in shaping Nephro Live. Dr. Dinesh Kullar is a chairman and head of the Department of Nephrology and Renal Transplant Medicine at Max Super Specialty Hospital, Saket, New Delhi. So welcome, sir, and I now invite sir to introduce our esteemed faculty for today's program. Over to you, sir.
Thank you very much, Dr. Mithilesh, and thank you, Intaj, for another wonderful opportunity to be able to interact with everyone who has joined us today as well. And it's my pleasant duty to one more time let everyone know as to who has joined us today. Uh, Certainly, every year, every time we are privileged to have one of the best known nephrologists join us in this forum to talk about the complexities of chronic kidney disease, the way we as nephrologists look at it and manage it as appropriately as possible. So many changes have happened over the years that we certainly need to recapitulate our knowledge about what is the best way of treating chronic kidney disease um, in 2025. So you may wonder, going by the topic of today's discussion, that's going to be acute kidney injury. You may wonder as to why, in the overall context of chronic kidney disease, are we wanting to talk about acute kidney injury? Because every time we spend more time to differentiate between these two entities, whether it is an acute kidney injury or it's chronic kidney disease, because we know acute is reversible while chronic kidney disease has a progressive and a relentless course. But the importance of AKI is to one more time highlight the fact that not every episode of acute kidney injury is reversible. If we do not take appropriate measures to stem the rot at the right time, that's one, and ensure that the whole problem has totally and permanently got reversed, there is a strong possibility that a given case of acute kidney injury may have some residual defect, which over a period of time may uh, uh, migrate into the category of chronic kidney disease, and that becomes relevant to what we have been discussing over the last few episodes of Nephro Live, which tries to make sure that the best known nephrologists of the country are able to disseminate the most appropriate and correct way of approach to chronic kidney disease to all those who are involved in the care of our patients, not just in our own country, but in few neighboring countries as well. So to take it forward today, I have a pleasant task of introducing a brilliant nephrologist one more time, someone who's a part of my department, and that's at Max Super Specialty Hospital, Saket, New Delhi. And it's a treat to know Dr. Abhishek for his sheer brilliance, his clinical acumen, and the way he takes exemplary care of his patients. His threadbare analysis of a given case is a treat as always. And today he's going to talk about the overall overview of acute kidney injury, and then also highlighting the fact as to why we are wanting to incorporate that knowledge into our broader perspective of chronic kidney disease. Up next, we will be joined by panelists, and as is always the case, you would again, I'm sure, want to compliment me that I have one more time been able to enroll one of the country's best known faces in the field of nephrology, and beginning with a very dear friend, Dr. Professor Ashwini Gupta. whom I had the honor of working as a colleague while in my erstwhile hospital, that's Sir Gangaram Hospital. And one of my most cherished memories about that hospital are also associated with Dr. Ashwini Gupta. One of the major reasons why I have so many fond memories of that particular place and thoroughly enjoyable. He is currently the co-chairman, Department of Nephrology. He actually needs no introduction to anyone across the country when it comes to the nephrologist. He's been a president-elect of Indian Society of Nephrology. He's been a past joint secretary. So all the relevant achievements possible in the field of nephrology, he has already been there. He has published more than 150 original articles and delivered more than 200 lectures. So a great, a brilliant nephrologist, vast a wealth of experience, and it's always a treat to learn from him. I had the honor of learning quite a lot of things from him, and as I said, some extraordinary memories of those days spent together. He had a brilliant academic career, and that has now been is being continued with his sheer brilliance as a nephrologist. Up next, we have another dear friend of mine, Dr. Vishwanath, who is the head of the Department of Nephrology at the prestigious Manipal Hospital, Bangalore. He's an adjunct professor in nephrology at KMC Manipal as well, and vast achievements to his credit. A very, very dear friend. I've known him from very close quarters. His again wealth of experience and knowledge as far as the various aspects of nephrology are concerned, including his special interest in pediatric nephrology. And he's been quite appropriately been awarded with the prestigious Dr. H.L. Trivedi Gold Medal, DNB Nephrology, Dr. Panikar Gold Medal in MBBS, Mysore University, and whole lot of other accolades to his credit. Thank you very much, Dr. Vishwanath. I'm sure he's going to be part of a wonderful discussion which we are going to have today.
Thank you,
Up
sir.
next, we have none other than Dr. Manjuri Sharma, and one of the best-known nephrologists from the eastern part of our country. She is a professor and head Department of Nephrology, Guwahati Medical College, Guwahati, and again, someone who needs no introduction to us nephrologists across the country. She's been holder of many fellowships. She also was the ISPD scholar whereby she had gone to Toronto and Canada. She's been president of Indian Society of Nephrology, East Zone, a whole lot of other achievements, and certainly her most recent achievement was the conduct of a very nicely conducted an annual conference of Indian Society of Peritoneal Dialysis, where certainly it was perceived as one of the best ever. She has been recipient of APSRA Award 2019 for her unique contribution to the Society of Assam. That's very, very creditable. Many publications to her credit. And welcome, Dr. Manjuri. And I'm sure, as I said earlier, it's going to be a great discussion. Now, up next, a young nephrologist who again has made a big name for her. A brilliant, again, very very intelligent Dr. Divya Bajpai, who's a professor, Department of Nephrology at the prestigious JHCS, GSMC and KEM Hospital, Mumbai, and her special, I would say, contribution to the field of nephrology has been her publications and the way she comes out with those excellent visual graphics, the abstracts of being on the editorial board of many of the prestigious journals. She has been a game changer when it comes to that, and certainly a lot of her innovative and brilliant ideas which add value to way we look at and read those articles which have been carefully analyzed by her. So she is an emerging leader to Indian Society of Nephrology, board member of South Asia Region International Society of Nephrology, subject expert nephrology. Whole lot of, as you can see here, large number of professional achievements, and certainly she's been on the faculty of so many prestigious bodies, and she's also the Joint Secretary, Women in Nephrology, the WIN, so as it called, ex-council member of Indian Society of Organ Transplantation, and she has been quite well deservedly been honored with so many of prestigious awards, as you can see here, so many publications to her credit, both in the Indian as well as the international journals of repute. So this is about the formal introduction, and I'm sure those who have joined us are in for a great treat today. So may I, at this stage, invite Dr. Abhishek to give us an overview of the topic of discussion today, and then we can follow it up with the wonderful discussion as is anticipated. Thank you very much, everyone, for joining in today. And this program has been becoming increasingly popular, has gained in popularity tremendously, and every time we started with just about 600, 700 people joining us, and finally the number was about close to 2,000 the last edition about a month ago. So this time, let us see how many can actually join us. We've been shifting the dates. I know it may be confusing for a few of you. My apologies as far as that is concerned, but this is keeping in mind of the busy schedules of so many who actually are inevitable part of this webinar series. Over to you, Abhishek, please.
So I hope my slides are visible, sir, and my voice is
Yeah,
audible.
yes, absolutely fine. And I truly hope they are going to move as well.
Yeah, hope so. So thank you, sir, for that kind introduction. And at the outside, apologies for my video not working. So I'd like to thank here Zenith and Intas for giving me this opportunity of presenting. And it is a privilege for me presenting in front of my teacher and mentors. So, to begin this discussion, I'll be providing a brief overview of this vast topic of acute kidney injury, its prevention and management strategies. And this will be followed by a discussion by our esteemed guests. So, acute kidney injury, as we know, is a heterogeneous syndrome which is defined by uh, just a moment, I think it's got lost somewhere. Are my slides still visible?
Yes, yes.
Yes, Abhishek. Yes, very much.
I think I can't see them. Just a moment,
My God.
sir.
So Abhishek, okay.
Abhishek, you
Okay.
need a separate laptop?
No, sir. I think they've just disappeared somewhere. Let me just go back.
Uh,
I think now they are visible.
yes, yes.
Yes. So AKI is a heterogeneous syndrome defined by rapid decline in glomerular filtration rate, resulting in retention of metabolic waste products, including urea and creatine, and dysregulation of fluid, electrolyte, and acid-base homeostasis. The KDIGO defines AKI as an increase in serum creatinine by more than zero point 0.3 milligrams per deciliter within a span of 48 hours, or an increase of more than 1.5 times the baseline, which is known or presumed to have occurred within the prior 7 days. It is also classified as a dip in urine volume to less than 0.5 milliliters per kg per hour for 6 hours. AKI is further staged into 3 stages based on the serum creatinine and urine output values. Stage 1 involves a rise in serum creatinine between 1.5 to 1.9 times the baseline, with a fall in urine output to less than zero point 0.5 mils per kg per hour for 6 to 12 hours. Stage 2 is a rise in creatinine between 2 to 2.9 times the baseline, with a fall of urine output less than zero point 0.5 milliliters per kg per hour for more than 12 hours. And stage 3 is rise in serum creatinine 3 times the baseline, or an increase in serum creatinine to more than 4 milligrams per deciliter, or initiation of renal replacement therapy, or in patients less than 18 years, a decrease in estimated GFR to less than 35 mils per minute per 1.73 meter square area. In terms of the urine output, stage 3 AKI is defined as a fall in urine output to less than 0.3 milliliters per kg per hour for more than 24 hours or complete anuria for more than 12 hours. So in 2021, the KDIGO made a consensus definition trying to harmonize the definitions of various terms like acute kidney injury, acute kidney disease, and chronic kidney disease. And they have defined acute kidney injury as a spectrum of disorders in acute kidney disease, uh, which is defined by the criteria as mentioned before. Acute kidney disease is diagnosed by structural and functional abnormalities of the kidney lasting up to 90 days, and chronic kidney disease defined as structural and functional abnormalities of the kidney, which lasts more than 3 months. AKI is a frequent diagnosis with an incidence that varies from 5 to 7.5% in hospitalized patients and reaches as high as 50 to 60% in critically ill patients. Both the incidence as well as the etiology of acute kidney injury varies between high, middle, and low income countries, as well as between urban and rural areas of the same countries. What does not vary are the adverse outcomes of AKI. It is seen that patients in ICU who develop AKI requiring dialysis report mortality rates ranging up to 60%. And even patients who survive with AKI have mortality rates twice as high as those ICU patients who survive who did not have AKI. Even the incidence of cardiovascular events is very high in patients who develop AKI. And moreover, the incidence of chronic kidney disease is nearly 3 to 4 fold higher among patients who develop AKI. The pathophysiology of AKI develops from summation of temporary activated systems in the microenvironment of the kidney, which leads to microvascular injury and congestion, activation of innate immunity leading to inflammation, acute tubular injury and cell death leading to tubular obstruction and back leak. There is a crosstalk with systemic responses like hemodynamic, neural, immunological, and oxidative stresses, and crosstalk with distant organs. So in the milieu of AKI, there is organ crosstalk and leads to damages to distant organs like brain, heart, lung, liver, intestine, and the immune system. AKI not only predisposes to, but also perpetuates CKD. And it has now been found that both biochemical as well as structural alterations lead to progression of CKD, which resulting from AKI, which finally progresses to end-stage kidney disease. Risk factors for people who develop AKI are those dependent on the patients, those involving the medications and agents used, and those including the procedures. The cause and AKI is largely divided anatomically into pre-renal, which constitutes around 30 to 60% of all cases of AKI, intrinsic, which constitutes nearly 40%, and post-renal causes, which constitute around 10% of all AKI cases. In a patient who presents with a raised serum creatinine or oliguria, a focused history and physical examination, followed by renal ultrasonography, can guide us with regards to the presence of chronic kidney disease. It can help us rule out obstruction. In the face of normal size kidneys, assessment of the volume status and looking at urine indices can differentiate pre-renal AKI, requiring volume optimization and specific management. One of the keystones for the management of AKI is urine analysis, which can point towards different intrinsic renal diseases and further specific management for the therapies. So urine sediment helps us guide with regards to narrowing the differentials of various AKI causes. One of the most common situations that people encounter are differentiating pre-renal AKI versus acute tubular necrosis, and urinary indices like urine osmolarity, urinary sodium, fractional excretion of sodium, fractional excretion of urea, and novel biomarkers now can help differentiate between the two. So biomarkers of kidney injury are those that measure glomerular function, those that measure inflammation and repair, and those that measure tubular function or damage. Despite a large amount of experimentation and research with regards to finding biomarkers for specific kidney disease and injuries, they are still today not commercially available, and most of them are still used in research setting. Moving on to the prevention and management of AKI. So the prevention and management of AKI involves management of the volume status, optimizing the blood pressure of the patient, discontinuing any nephrotoxic drugs, and making drug dosages, adjusting drug dosages as per the renal function. As indicated, renal replacement therapy may be used for managing AKI and treatment of the specific causes of AKI. The volume status is a very important assessment when treating a patient with AKI. It is done by clinical parameters, by laboratory parameters, including bioimpedance analysis. However, the gold standard is invasive monitoring. Nowadays, point of care ultrasound has come up as a great guide for managing acute kidney injury and volume in acute kidney injury. We use the pumps, that is the heart, the pipes, that is your large vessels, including IVC, hepatic, portal vein, and intrarenal venous Dopplers, and the leaks, which are your lungs and your B lines, to guide regarding volume status of patients with AKI. So there are settings where fluid administration can successfully prevent AKI. These include pre-renal AKI from hypovolemia, patients receiving radiocontrast media, those with tumor lysis syndrome, those who are undergoing surgical procedures in which there is a large reduction in intravascular volume, patients with burns, hemoglobinuria, myoglobinuria, and sepsis and shock. So the approach to fluid replacement is divided into three phases. There is the resuscitation or rescue phase, followed by a phase of replacement fluid and optimization, followed by maintenance and de-escalation. Trials throughout have now found out that crystalloids are the fluids of choice. However, when deciding as to what crystalloid solution, whether a balanced crystalloid solution or normal saline to be used for resuscitation, various randomized trials have still not been able to give us the perfect answer. However, this new trial, BEST Fluids, which was conducted in a very specific population of patients receiving a diseased donor kidney transplant, showed that IV therapy with balanced crystalloid solution, it reduced the incidence of delayed graft function when compared to a hyperchloremic solution like saline. Whether this can be extrapolated to the general population, that's still a question for debate. There are few important considerations using various solutions, and it has to be pointed out that albumin should be considered when substantial amounts of crystalloids are required to maintain a mean arterial pressure in patients, especially with those with sepsis. Now, blood pressure targets, it has been seen in various studies that patients with higher MAP values tend to have lower incidences of AKI, and hence MAP goals in AKI are often higher than normal. However, specific targets should be individualized based on the hypertension status, comorbidities, degree of peripheral artery and renovascular disease, and the etiology of AKI. The other main category of therapy used to increase blood pressure is vasopressors. They are recommended when fluid resuscitation fails to meet MAP goals. Norepinephrine is the first choice drug in many cases, followed by vasopressin as a secondary option, as per the surviving sepsis guidelines. Based on the clinical considerations, choice of vasopressor may be demarcated specifically, like terlipressin for hepatorenal syndrome. Diuretics are not associated with clinical benefits in preventing AKI or decreasing the need for renal replacement therapy, renal recovery, or decreasing in hospital mortality. However, they guide us with regards to fluid responsiveness in patients, and they are recommended to manage the fluid overload and electrolyte disturbances in patients with AKI. Studies have been done for various drugs to look for benefit with regards to prevention and recovery in AKI. However, most of them have been found to be ineffective. Patients in AKI do require renal replacement therapy, indications involving volume overload, which is unresponsive to diuretic therapy, persistent hyperkalemia despite medical therapy, severe metabolic acidosis, overt uremic symptoms of encephalopathy, pericarditis, and uremic bleeding diathesis. When it comes to the modalities, the spectrum of replacement therapy depends on the severity of illness, with conventional intermittent hemodialysis, prolonged intermittent renal replacement therapy, continuous renal replacement therapy, and peritoneal dialysis providing a good armamentarium for renal replacement therapy. With regards to the debate between early versus late initiation of kidney replacement therapy in AKI, large RCTs have by and large settled the debate with no benefit of early initiation of dialysis in AKI. With regards to extracorporeal cytokine removal, there is scant but doubtful data with regards to benefits of extracorporeal cytokine removal in preventing and recovering AKI. However, this new study recently published in patients undergoing cardiopulmonary bypass showed that there was a significant reduction in incidence of AKI in patients receiving extracorporeal blood purification. Finally, few words about contrast-associated nephropathy. Contrast-associated AKI is a broad term that refers to AKI occurring shortly after administration of iodinated contrast that may or may not directly be caused by the contrast material. The risk factors are patient-related, like the presence of CKD, especially diabetic nephropathy, presence of reduced kidney perfusion from heart failure, hypovolemia, or hemodynamic instability, or procedure-related factors, including the dose and type of contrast agent and the specific procedure vis-a-vis intra-arterial versus intravenous and interventional versus diagnostic angiography. Various algorithms have been developed to prevent the development of contrast-associated nephropathy. However, the only intervention till now that has been proven to be effective in preventing contrast-associated nephropathy is hydration with isotonic saline. Recently, the Canadian Association of Radiologists published a guidance on contrast-associated nephropathy, wherein they recommended to proceed with intravenous contrast media if the clinical situation and diagnosis warrant the use of a contrast without any screening. Also, they gave a cutoff of EGFR more than 30 and the absence of AKI as parameters where we can proceed with intravenous contrast media. Finally, to conclude, AKI is highly prevalent and is associated with significant morbidity and mortality. It predisposes to and leads to progression of CKD. Therefore, recognition, prevention, and treatment of its complications is of utmost importance. Currently, there are no established pharmacotherapies to recover AKI, and the treatment strategies for AKI comprise hemodynamic stabilization, the eviction of nephrotoxins, and the treatment of AKI complication. Thank you.
Well, you very much, Abhishek, and I'm sure everyone will agree. Nothing could have been better. Oh, what an excellent presentation and mesmerizing one. Thank you so much, Abhishek. You've given a fantastic overview and a complete gist of what everyone should remember about AKI, the factors involved, the propagation of AKI, and then of course um, coming across the entity of AKI through the various definitions which we have now, which have made our task relatively easier ever since we had the rifle and the akin and now finally the KDCO definition. So has removed a lot of ambiguities, and you have very nicely alluded to the various aspects of AKI in the best possible manner, at least I can think of. Nothing to add really. So at this stage, may I invite all our elite panelists for yet another fruitful discussion, a wonderful discussion. We will now try to address many of the key points which Abhishek has highlighted, and I think we will elaborate on them. Give you the perspective of the among the most experienced nephrologists of the country, and may I at this stage invite Dr. Ashwini Gupta for the first question which I have in mind, and that obviously will relate to the definitions. And it's all about saying that yes, we have come a long way from the older classification of acute renal failure, and then now we are talking about acute kidney injury. We certainly want to be a little politer when we are talking about the event of some kind of injury. So, Dr. Ashwini, Abhishek did talk about the KDIGO criteria and the fact that the serum creatinine rise of more than 3.3 milligrams per deciliter or a urine output of less than zero point 0.5 ml per kg per hour for 6 hours. Now this criteria, we at times when we discussed among ourselves, we believe they are too sensitive. But do we need some better biomarkers beyond serum creatinine? You see, we have often resorted to criticize serum creatinine a lot, be it in the context of chronic kidney disease and now in the context of AKI. We say that, well, there are a lot of fallacies with the serum creatinine, but at the end of the day, we fall universally accepting the importance of serum creatinine. Until the time we find a better alternative, we're sticking on with the time-tested serum creatinine. But I would like to have your opinion. Do you believe serum creatinine gives us the kind of information which you are wanting to have it from it, or certainly you say no, not in 2025. We should rather be talking about the newer things which we have in mind, and we'll be discussing in a short while. Yeah.
Thank you, Dr. Kular, for your kind introduction and involving me in such a good kind of literary activity. I'm really thankful to you, and I could revive certain of the things because of your lectures and because of what needs to be discussed today. And you see, as you have told and Abhishek has told, for last many decades we have been talking about renal failure, acute kidney injury, and now we have good definitions, rifle to akin to presently KDCO. So currently, AKI is defined and staged by changes in serum creatinine and urine output. Individually, each has limitations, and combined, they give better information and prediction of AKI. But still, it is not 100% diagnostic of early renal injury in terms of onset of renal damage. So, because as you have already highlighted, that for serum creatinine, it to be evident as a marker of AKI, it takes few hours to 78 to 72 hours before the actual start of renal damage. And it depends upon many variables, like these patients are having sepsis, liver disease, pancreatic disease. They have problems of nutrition as they are in hospital for number of days, and muscle mass. So many of these parameters they reflect upon the creatinine assessment. So these are limitations. And second surrogate marker is urine output. Though changes in the urine output occur rapidly within few minutes to few hours, however, it is neither sensitive or specific as far as AKI is concerned, because 20 to 30% of AKIs can be non-oliguric. So there it will not be a good parameter. And also, we have to see that there is a difference between dysfunction and damage. Take, for instance, pre-renal azotemia. There you will find derangement in the renal parameters, but still there is no damage. So that is a functional change. So that is why there is role of some biomarkers. And why they are required? Because, as you have already mentioned, Abhishek has also told that early detection of AKI is very important to decrease both the morbidity as well as mortality in the patients who are sick and having AKI in ICUs or cardiac surgeries. So established AKI on an average mortality ranges between 40 to 50%. And actually, I have been listening this mortality of 50 to 60% overall for last 30 years or so. We have all gone together, and this figure has not changed. Say, obstetric, we use 30%, surgical 70 to 80%, overall 50%, and still the overall mortality is 43 to 45% if we look at start AKI trial. So biomarkers, they detect kidney injury when the function is still normal and only mildly or transiently impaired in critically sick patients. So there are two. Earlier, so many markers were brought into the fray, but now it has come to mainly two or three markers.
We,
TIMP2, this
we
tissue.
are going to talk about that, Dr. Ashmi. We
Okay.
are certainly going to talk about that as well. But then, point
Yes.
well taken. I think that's exactly what I was expecting from you. That no matter how much you praise or criticize serum creatinine, at the end of the day, you have to rely
You have.
on things as basic as serum creatinine and the urine output. Till the time we have some easier. Or I think more precise or something, as you very rightly pointed out, can pick the injury young, which means rather at early stages, whereby so many times by the time creatinine rises, we all know the significant damage, significant impact on the renal function has already happened. So thank you so much for those very, very valid points. And that's just the right kind of quick start that we wanted to have for this discussion. So this one is for you, Dr. Vishwanath. Dr. Vishwanath,
Yes.
we have been listening to what Abhishek said, that it's a rise of serum creatinine. But as we all know, acute kidney injury is like a catastrophic event. And so many times patient is not going to be aware of the baseline serum creatinine. So what do you do then? I mean, so many times, I mean, we know that no one gets the creatinine, his or her creatinine checked at regular intervals. So do you think there is a shortcoming of this definition when we don't know the baseline, or you have to wait for now 48 hours before you can say, okay, this is the change over the previous over the last 48 hours, and then now you can safely make a diagnosis of AKI. So what is your take on this?
In AKI setting, most often we are talking about in critically ill patients. So most of the times they come critically ill. We don't know what is happening. So best would be like what we do in our day-to-day practice. So we see the patient, assess the fluid status, and then see how he responds. So I think whatever we have, KDIGO definition is still very valid in our day-to-day practice. Rise in creatinine, urine output, And probably other parameters are very important, like whether oxygen requirement, ventilation requirement, how is the mentation of the patient, acid-base status. Probably they will add to us to contribute and take a decision in a faster way rather than waiting for 48 hours or 72 hours. Most of the clinicians in our day-to-day practice, I'm sure you would agree, we see whether patient is hypercatabolic or whether patient is overall not doing well, whether we need to do early dialysis. And as we all know, these definitions have its fallacies in special situations like be it pregnancy, chronic liver disease, post surgery. Probably we would like to intervene much earlier. Chronic liver disease, we may not know. Definitely, the rise in creatinine may not be like what regular patients have. So all of us know that CLD creatinine may not rise at all. So in these situations, maybe we should take all these factors into account and then consider whether creatinine alone is a good marker or enough for us to define AKI. So we should probably take the total picture into view and then define. But as of now, we have urine output and creatinine criteria, which is probably the earliest one. And they are the not only ones which we should take into consideration.
Well, thank you. I think that's very nice clarification for that, Dr. Vishwanath. Dr. Manjari, I think I'm taking it forward. We are not here to criticize the KDIGO definitions or the other definitions, but and Dr. Ashni had also alluded to the fact that quite a significant number of AKI patients can be non-oliguric. So you may not have a reduction in urine output. So is it so? Please, for the sake of those who have joined us today, please clarify: is it a rise in creatinine and a reduction in urine output, or a reduction in the urine output? So that's one clarification which everyone, because so many times we may believe that creatinine is rising on an acute basis while the urine output is not decreased. Will it still qualify to be labeled as acute kidney injury, where, as the question was asked to Dr. Vishwanath, we may not be aware of what the baseline serum creatinine was? So that's just to remove any kind of ambiguities in everyone's mind, because all those who have joined us today are actually going to be responsible for the initial management of these patients at the early stages before they even come to the nephrologist. So that one is for you, Dr. Manjri. Yeah. So do you believe we need to combine urine output and serum creatinine always? Yeah.
See, I think the AKI patients that we see as nephrologists are those AKI patients who actually have the established AKI. We do not get patients in the initial stage. So this is one marker. I think we have to stick to serum creatinine as the marker, surrogate marker for kidney dysfunction, because creatinine value is known to not only the nephrologist, but the importance of the value of creatinine is known to all the physicians. And basically, these AKI patients are all the time not admitted in the nephrology department. They are most of the times admitted either in the medicine ward or in the ICU of the different wards, right? So I think it is, we have to take for all practical purpose the value of creatinine. Obviously, the second question comes about urine output. Yes, how Dr. Aswini had said, we get many patients with non-oliguric renal failure. But how do we make the diagnosis? So we stick to the value of creatinine only. I think the value of creatinine should be included and given priority in practical purposes, and then we have to correlate with the urine volume as well.
So here we have an interesting question by Dr. O.P. Singh, who wants to know whether there is any role of EGFR in classification of kidney disease, and in the context context of AKI or acute and CKD, because we know the importance of EGFR when it comes to CKD, but is it as relevant in AKI as well, and especially in patients where you are making a diagnosis of acute over and above an underlying chronic kidney disease? So the role of EGFR in classification of kidney disease, whether it is acute or not. Right?
The question is to me?
Yeah, Dr. Manjri, yeah. This was an extension of what we had asked you earlier, and this was a question in the chat box by Dr. O.P. Singh, who wants to know the role of EGFR in classification of kidney disease, right?
I don't think so. It is too much of importance in AKI patients, because for AKI patients, we do not depend only on the EGFR. There are other parameters as well. Also in the market, we have the biomarkers. Nowadays, we can even check by the Nephro check, right?
Yeah.
The Nephro check is available, so we can know who are those patients who can develop AKI. So we can pick up those at-risk patients. So we have to go mainly on this surrogate marker, the age-old the old concept of measuring the creatinine in AKI patients, then relying on the EGFR, how we do in CKD patients.
Quite true. And thank you for clarifying that. And that was a very important point for everyone to understand. Dr. Divya, we have been quite fascinated by what POCUS or point of care ultrasound, the way it can help us, the way it has actually revolutionized our management, the way we look at making the correct diagnosis in a patient who is in front of you, beyond just looking at the skin turgor or applying our clinical judgment and using our stethoscope. I think POCUS has gained an equal importance, or maybe even more, as compared to so many things we had in our armamentarium to clinch the diagnosis. So where would you put the role of ultrasound or looking at the various aspects and confirming the diagnosis or making a diagnosis of acute kidney injury?
Yeah, thank you, Dr. Khulla. That's an amazing question. Actually, one of the most important thing to discuss in 2025 when we are discussing AKI. And also, a thank you for letting me be a part of this very interesting and educational program. I'm really happy to be here. So, talking about focus, actually, in 2025, I would say that, especially for critically ill patients, our round should definitely not be complete without an ultrasound investigation or examination of our patient. Especially in when we are talking about patients with renal involvement, ultrasound is so important. It can directly rule out causes of post-renal AKI. Like you can just go check whether there is any hydronephrosis, whether there is any obstruction, bladder outlet obstruction, ureteric obstruction. So you are completely ruling out a complete different set of diagnoses, which will have a different management. Then, as one of the viewers had asked about AKI on CKD. So again, there's a role of ultrasound there. If we do a ultrasound in a patient with AKI and we find small shrunken kidneys, very ecogenic, bright kidneys, or kidneys with very high RI, it might be possible that they have a baseline CKD, and now we are thinking of something which has happened acutely on a decreased on someone who has already have a decreased GFR. So that's an AKI on CKD. Again, very important utility for ultrasound bedside and diagnosis of that. So that was ultrasound. Now let's talk about focus. Focus is something which has really revolutionized our critical care now. It's a clinician performed goal directed ultrasound examination which is done bedside to answer focused questions at the bedside. So what I do in my practice is that I start my round with checking the IVC whenever I see a patient of renal involvement. IVC can be collapsed or it can be plethoric. Then it tells me completely different two scenarios. That's a very important assessment of not only of volume status, but also an indirect assessment of the cardiac status of the patient. So then we can also do VEXUS, which tells about the venous congestion and all those things. We can do lung ultrasound, which tells us about the whether there's any pulmonary edema. It can be cardiogenic or pneumogenic origin. So focus and ultrasound taken together can differentiate pre-renal, post-renal, intrinsic renal AKI, and it will also tell us a volume status of the patient. So I would say the message here is that for a critically ill patient, it is a very important tool, and do not complete your examination without book.
Well, I'm glad you highlighted the most important aspects of what goes on in a typically nephrologist's mind when we are wanting to assess the volume status of a given patient. And I think that's the very essence and basic of making a correct diagnosis when it comes to clinching whether your given patient has volume overload or not. And this is where things like point of care ultrasound comes to our rescue. Abhishek did talk about the fact that we should also try to rope in the part played by bioimpedance. And I think unless you know the correct volume status, you will be failing in your duty to appropriately manage this patient. And for those who have joined the non-nephrologists today, please accept it as a part and parcel of your duty as well. It should not be left to just the nephrologist to be able to know whether a given patient has volume overload or not. Edema may not mean volume overload. I mean, we as Divya had highlighted the importance of IVC, and that's something which everyone of us is now accepting the importance of. And not every edema means volume overload. You look at the IVC, it may actually be collapse. So that is basically we need to look at the effective circulatory volume of a given patient rather than the compartment wise. And similarly, we have been quite excited to learn the nitty-gritties of bioimpedance. You come to know the way it has helped. We were talking in a previous session about its role in managing dialysis patients. Same holds true for managing our AKI patients as well, because diuretics, as Abhishek said, may not directly have a mortality benefit, but then yes, they do have a very significant role to play. And unless we know the correct volume status of a given patient, we certainly are not going to be do justice to the way we manage them. Well, thank you very much, Divya, for those very excellent points. So this one is for Dr. Vishwanath. Dr. Vishwanath, Dr. Ashwini did mention about the role played by biomarkers. We have been listening a lot about NGAL for one. All right, and over a period of time, the KIM1, the insulin-like growth factor binding protein, so a whole lot of them, which always gave us a lot of optimism, yet have not really been playing a big role in our day-to-day practice, barring NGAL in certain situations. Few people may actually be doing it, but yes, when I talk about the population, the majority of the nephrologists included, we don't give too much of importance to biomarkers as of today. What is your take on the role of biomarkers in 2025?
Thank you, sir. Thank you. Thanks again for inviting me. Basically, we had done a study on NGAL, and as we all know, NGAL has been shown very positive results in post cardiac surgery. In regular AKIs, it has not shown much of benefit. And we did a study in our set of patients. In fact, it was one of the thesis topic for a postgraduate. What we have seen in our experience is NGAL alone may not contribute to early recognition. So, in fact, most of the studies have shown NGAL with KIM1, NGAL with TIMP, these put together probably give a better idea whether AKI is setting in. And most often, if we can recognize early, we can take preventive steps. But as you mentioned, these access to these is not easier, and most often it is at the research, and then the one molecule itself to test takes a lot of money. In fact, when we did NGAL, we had to fund it with from the department, and then it is not easy to do it on a day-to-day practice. So probably still we are there where we started about 5 to 10 years back, and we haven't progressed from there. Probably in post cardiac surgery, post surgical, maybe to some extent in pregnancy we may get some idea, but not in regular sepsis related. We should still probably go by clinical parameters, not only urine output and creatinine, but other parameters like oxygen requirement, acidosis, electrolytes probably would contribute more towards assessment and taking earlier preventive actions.
Thank you very much, Dr. Vishwanath. Dr. Ashwini, this one is for you. We keep on hearing a lot about, as Abhishek said, there has been a change of nomenclature. We nowadays refrain from using contrast-induced AKI. We use typically contrast-associated, or even better still, few people believe post-contrast AKI, regardless of whatever the etiology may have been, and whether we want to incriminate the contrast, iodinated contrast or not. So, but we know that there are two schools of thought. One which believes that contrast associated AKI, or sorry, contrast induced AKI does not does not happen. That's one school of thought. While others believe, no, it is definitely an entity. Beware of its possibility and take utmost care so as to be able to prevent it, because once it happens, it can have serious repercussions and implications. So, if I may ask you, Dr. Ashwini, which school of thought do you belong to? Because I remember you had given a fantastic lecture on, it was almost like 10, 12 years ago, maybe longer. And I still remember, I mean, a few of the points which you had made in that particular talk, very, very interesting as always. But that was way back, and there's been a lot of changes in our understanding about contrast. This is because every day we get flooded with the consults from other departments. Look, the creatinine is 1.5. I desperately want to give contrast to this patient, typically from a cardiologist or oncologist, but the creatinine is holding me back. What do I do? So, what is your take? Is Do we go ahead? And if yes, what kind of precautions that Abhishek had talked about, and whether the isoosmolar or the low ionic low osmolar contrast media, they have a role to play here. So, what is your typically take on this? Yeah.
Thank you, Dr. Kuller. I belong to the that group which believe in first clinical assessment, history, examination, and labs. Use it when it is indicated, and do not shy to do the contrast study if it is really indicated, contributing to a diagnosis in a life-threatening situation, and also it is going to change the line of management. You should not be overcautious. That is one. And now, actually, whether you have already raised a contrast-induced AKI exists or not, because it has changed the terms contrast-associated AKI, post-contrast AKI. So it is, I think, why we talk about 10, 12 years ago. Last to last year, you did the Delhi Nephrology Society meeting, and in that, your first lecture was on this, whether contrast-induced injury this term is there or not. And it was very ably, the orator had said that it is like a ghost hanging in a haunted tree. So, whether it is there or not, we are, I think, more worried about it than actually it is existing. Because incidence of contrast associated or contrast induced AKI in patients who are not at risk is less than 2%. But patients with moderate to mild renal insufficiency, it can range between 9 to even 50%. So, what we should do, because contrast management safety committee guidelines, Abhishek has mentioned about Canadian guidelines, and there are American College of Radiology and NKF guidelines. So, low osmolar contrast media, I think they are better for a mild to moderate renal insufficiency, or they should be used when, always be used when it is GFR is less than 30 ml. And isoosmolar, so, incidence of the contrast associated AKI is lesser with low osmolar as compared to isoosmolar, and it is high definitely with high osmolar, and which nobody is using these days. We have to use the safest possible dose. We should hydrate the patient well, and associated medications like NSAIDs, aminoglycosides, amphotericin B, which are being given in ICUs at that time, if they can be avoided, they should be avoided for at least before and 1 or 2 days after the use of contrast.
Well,
So
that very,
basically, these
yeah.
will be the important things.
So very, very nicely, I think it's a very strong message that Dr. Ashwini Gupta has made, that we should not discourage the judicious use of iodinated contrast whenever it is indicated. And if your patient does not have any kind of pre-existing chronic kidney disease or some other comorbid factors, the incidence of contrast associated AKI may actually be practically zero. It's only in those people who have diabetic kidney disease or some variety of chronic kidney disease definitely are more predisposed, and the concomitant, the comorbidities are to be held responsible. But those comorbidities are actually going to compel us to go in favor of a contrast. So I think the word is judicious use of contrast. And of course, we have to guide our other colleagues that yes, if you have to give it in people who are predisposed, I mean, preferably, definitely avoid high osmolar and go in favor of isoosmolar, where you will probably encounter fewer incidents of kidney injury. Well, I think that's very, very clear and loud messages for everyone to remember. So moving on, and let's try to shift to the etiologies. And Dr. Manjri, we know that we encounter a lot of acute kidney injury episodes related to infections, be it leptospirosis. In fact, leptospirosis induced AKI is one of the commonest causes of acute kidney injury in some parts of the country. Malaria, dengue, and we had a lot of traumatic experiences with COVID as well. So I think all these are very, very common causes of AKI. So would you make it a must to screen for AKI whenever you have any of these medical conditions, especially if they take a more serious course? Yeah. You are on mute, Dr. Manjri. Kindly unmute yourself. Yeah.
Thank you, sir, for a very important question. And then you were talking about malaria. Malaria was an epidemic few years ago, but still we do get a lot of patients with malaria. We do get patients with leptospirosis. So I think this term, there is a terminology called tropical acute febrile illness, TAFI. And it is very, very common in the tropical places, including India. And the incidence and prevalence can go as high as up to 10 to 20%. So there are a lot of studies on TEFI, and they have found out actually some risk factors like hyperbilirubinemia, respiratory failure, male patients, obesity. So when you have these risk factors, I think you have to make the test mandatory for all these tropical acute febrile illness patients, so that we can pick up the make the diagnosis of like AKI in the early stage, and then we can manage the patient better, so that we have a better outcome.
Good. Thank you, Dr. Manjri, for that clarification. And I think let's move on to the actual management. And Divya, this one is for you. How do we balance fluid resuscitation? There were two schools of thought. More is better, than more is detrimental to the propagation of AKI, and we have come one big circle as far as the fluid resuscitation is concerned. Few people would say, okay, be as liberal as possible. Then came the as an afterthought that we fell in a trap by giving too much of intravenous fluids, without, of course, the topic which you had talked about, and that's the POCUS, the role of POCUS. Short of that, and where of course those facilities may not be available, and you are relying on your clinical judgment, what would be your take? Whether to give too much of fluid upfront to prevent and manage in the initial stages, or remain very frugal as frugal as possible, and not to give too much. Yeah.
Yeah, thank you, sir. A very pertinent question related to management of AKI. And I am with Dr. Gupta's, I'm in his team, the team of doing a good physical examination of the patient and thinking of patient as a whole and the bigger picture while treating AKI. So how I take it is like this, and what the evidence also supports now is this. The rationale of giving fluids is to restore tissue perfusion. In absolute hypovolemia, like if you have a patient who has cholera, who's like pouring lots and lots of diarrhea, vomiting, definite a post-surgical patient who has huge drain output, an obstetric patient who's having an obstetric hemorrhage. These are some true hypovolemic patients who can still exist in 2025. So in absolute hypovolemia, you have to give fluids to maintain renal perfusion and maintain and to correct the decrease cardiac output. By improving cardiac output, you will definitely help in maintaining the perfusion. However, most of the patients, after being in ICU or in hospital for more than 24 to 48 hours, are out of this. And then when they develop hypotension or oliguria, which were the topmost causes of why fluids were given, there was a huge study done in all ICUs, and the topmost causes were these: hypotension and oliguria. Majority of patients are not hypovolemic after being for some time in ICU or in hospital. Rather, they are hyper or euvolemic. So, in absence of an absolute hypovolemia, which we rule out by, of course, by focus, but also by clinical examination, hypotension, tachycardia, dry mucous membrane, straight leg raising test, improving blood pressure and pulse volume. So, if that is not there, then only because someone is oliguric, that does not mean that they will respond to fluid. Rather, fluid can do more harm. Actually, in a pediatric study, it was seen that each 10% gain in total body volume, that is 10% positive fluid balance, increases the mortality in an ICU pediatric patient by 1%. So, fluid at till one point is okay. After that, it is more harmful. So, I would suggest I will fall in the team of doing a cautious examination, ruling out hypovolemia. If it is there, I'll give fluid. I'll prefer crystalloids over colloids. That's the take now in this with the evidence-based medicine. Then, as Dr. Abhishek was alluding to, we have resuscitation, replacement, and maintenance phases. So we'll go closely, we'll follow those. Once we have reached a patient with ATN, established ATN, the pre-renal thing is ruled out, then I would just give the maintenance fluid, which will be somewhere around less than 800 to 1 liter in a patient who is oliguric. Throughout this time, I would try to make the best use of focus if available. If not, then simple things like passive leg raising, or even if echo is available, then echo can help us a lot in that. So that was about fluids.
Yes. So points well taken. Very, very pertinent points. Thank you very much. Yeah, and I think you did mention about the differentiation between the role of crystalloids and colloids. But taking it further, Dr. Vishwanath, that is that's for you. Uh, Akhilesh did mention about some role of the balanced crystalloids. So,
Yes.
do you believe that hyperchloremia induced by the standard, the normal saline, vis-a-vis the ringer lactate or the balanced crystalloids, where you will expect chloride levels of 110 or better still 97, are going to make a difference, especially like the way we deal with our transplant patients in the immediate post-operative period. We end up giving them something like 10-15 liters of
Yeah.
fluid, and if that is going to be normal saline all the time, look at what kind of chloride levels we can encounter. So do you
Yeah.
believe, because they are little expensive, but certainly cost will be number two criteria to talk about, to discuss about. First, it should be pure science. So if do you strongly believe balanced crystalloids have a role to play?
Definitely. In fact, Dr. Divya mentioned about that briefly. So, balanced crystalloids have definitely shown, even in the study, SMART study, where they had seen, though the difference in between balanced crystalloids and colloids was 1 to 2%, definitely it would probably make a difference in people whom we are giving fluid. Probably, but more important than that would be what is the indication of giving fluid. Suppose somebody coming with hypertension, lot of fluid loss, then normal saline would be all right, unless somebody has come with sepsis. So probably we should choose the fluid depending on what is the indication we are looking at, rather than blindly thinking chlorides may do harm. Transplant patients, we have seen it doesn't make much difference, though most of us would probably give half of that and half of this just to make sure that we are not loading the patient with sodium or chloride. But probably we should choose the fluid based on the indication. Hypovolemic shock, definitely normal saline is not going to do any harm. Sepsis, somebody is already volume not depleted, so probably we could probably go with a balanced crystalloid. And in rare indications, probably we can even consider albumin in specialized situations. And of course, we should all consider and take these fluid with a lot of caution. And we should also think that it is not that one size fits all. not that this fluid fits everybody. So we need to choose the fluid based on what is the indication we are looking at. And as Dr. Divya mentioned, we should be probably more have a hesitant approach to the persistent fluid rather than just filling them up by seeing their overall status. Many of us would have seen, most of us would disagree with ICU. Whenever a patient comes out of ICU, either they're dehydrated or they're overhydrated. And most of us will think, why ICU it always happens. And I'm sure all of us would agree, nephrologists are probably the better people to assess the volume status of a patient.
Quite true, quite interesting as well. I mean, so many times we are at loggerheads as far as this aspect is concerned with our critical care colleagues, and by that time, as is the question asked posted by Dr. Prasad, he wants to know when do you believe the AKI recovery has taken place, and I would want to highlight this aspect that once regardless, and I'm going to ask that to Dr. Divya to take it up. But before that, even when the actual recovery has taken place, and patient is shifted out from the ICU to the wards, we end up spending another week to 10 days taking care of the extra water from the body. You see,
To
because they would
stabilize
have
them.
gained something like 10, 15 liters of fluid by the time
Absolutely.
they are shifted out, and the relatives refuse to recognize them in the first encounter. So Divya, Dr. Prasad has asked a very pertinent question: how to define recovery in AKI, and of course, would it be advisable to discharge the patient or refer to a specialist care? Because so many times may not be known the nitty-gritties, the nuances of the way we should follow up a given patient of AKI subsequently. And that's the essence of today's discussion. We are wanting to prevent CKD from happening. And if you act at the right time, manage our patients with AKI as appropriately as possible, there certainly would be mitigation of chronic kidney disease. Yeah.
Yeah, very important question, and especially if it has come from a non-nephrologist, a person in the audience, it's extremely important. It's
So to
very
interrupt
important to
you,
think about it.
interrupt you here,
Yeah.
Divya. I think if I have recognized correctly, Dr. Arun Prasad could have posted this question. He may be a non-nephrologist, but he takes a lot of keen interest in the field of nephrology. He has set up his own dialysis unit at the government sector. That's the South Delhi Municipal Corporation, and a lovely treat to watch his dialysis unit. Over to you, Divya.
Wow, kudos to him. Actually, the type of question he has asked, it makes it actually tells what kind of passion he has for these type of patients. So a very important thing in understanding AKI is when to realize that kidneys have started recovering, because those times we switch our modalities. If suppose we are dialyzing, we would like to stop dialysis, because dialysis in its way, hemodialysis can also a little bit impede the recovery which is ongoing. So simple things: if your urine output was low and now it has started increasing, for example, if patient was passing less than 200, 300, and it is doubling every day. Today it is 200, tomorrow it's 400, then 800, then maybe 1000, 1200. So an increasing urine output, a stabilized or a rather declining trend of BUN and creatinine. It is also important to note that BUN and creatinine lag behind. So first output increases, BUN and creatinine may still be high, but it eventually comes down. Patients who are hypercatabolic, having hyperkalemia, hyperphosphatemia, those signs tend to go down. And patients, the general condition also improves. So all these are the parameters which tell us that the cleaner recovery is now happening. We should now, when we were restricting fluids, now we should give fluids, at least to ensure that they are not too much negative now. Many of these patients, when they go into polyuric phase, they develop hypokalemia, hypocalcemia, because the tubules have not yet recovered and they lose all these electrolytes. So we need to take care of those. Something which we do in our practice, because we are from a government hospital and the test is freely available, is 24-hour creatinine clearance in urine. That tells us the exact type of recovery which is happening, and we can see it is improving daily. The amount of creatinine which is coming out in urine, that is something which can be done if you are in a dilemma, especially when to stop dialysis or not. So these are very important points, and the one which you have alluded to, that whether these patients should see a nephrologist. So I would say that at least once before discharge, they should visit a nephrologist. They can decide whether they would require a long-term follow-up with nephrologist or not. Majority of AKI might have some residual damage, which can lead them to go towards chronic kidney disease in future, and we do play a role there. So at least one talk or one look at the patient will make a lot of difference.
Well, thank you. Excellent, Divya. Dr. Ashwini, there's a question by Dr. Deepak Patel who wants to know the role of SGLT2 inhibitors in causation of AKI. Is it as a cause and as a treatment of choice? Is what he wants to know. So there are two components of my question. So first, I will pose, and this is something which we had discussed when we were talking about SGLT2 inhibitors in the context of diabetic kidney disease in our previous edition. And I would request you to one more time differentiate for those who have logged in today between a physiological decline in GFR as caused by both RAS inhibitors as well as SGLT2 inhibitors vis-a-vis an established AKI, which may not be the case, and the mere increase in serum creatinine should not tantamount to be labeled as an AKI, an established AKI, and discourage us from further continuation of SGLT2 inhibitors. So that's the first component of my question. This has actually been asked by Dr. Deepak Patel. Dr. Ashwini, the SGLT2 inhibitors as a cause of AKI.
Yes, it's absolutely right, because if you look at the mechanism of SGLT2 inhibitors, so what they do is they increase the afferent arteriolar concentration by inhibiting the tubuloglomerular feedback, because they are causing more of diuresis, natriuresis, and when distal convoluted tubular sodium concentration is high, there is a negative feedback and there is afferent arteriolar constriction. So they induce modest but acute decline in GFR by approximately 3 to 5 ml per minute per 1.73 meter square body surface area. And this rise should not be taken as AKI when you are starting a patient on SGLT2 inhibitors. You should ask them to take more fluids, remain hydrated, and it should be stopped only if there is rise in serum creatinine by more than 30% of the baseline value. So till there is rise in creatinine by 30%, you should not withdraw. You should ask them to take a good amount of fluid intake, and if they are taking associated diuretics, they should stop, because they act as a diuretic as well as antihypertensives also. And at time we have seen that when RAS blockade is done, and along with simultaneously we have started SGLT2 inhibitors, then the rise in creatinine is more significant. So ideally, you should first go for RAS blockade. Once patients' renal functions are stable on that, then you should add SGLT2 inhibitors. So that was one part of question, that they can cause acute decline in GFR, rise in creatinine, and up till 30% rise. It should not be a case for stopping AKIs. And
Now the
second
second
part
part.
of question.
So I'm coming
Okay.
to the second part, Dr. Ashwini, and I think this was one aspect where you believe that yes, you should continue to repose your faith in
Yeah.
SGLT2 inhibitors regardless of the initial decline, which is bound to be there. And again, one more time to highlight the point that only those who actually experience this kind of a decline in the initial stages, but then gets arrested, are the ones who probably will
Benefit
gain the
more.
maximum
Yeah.
out of this kind of decline. But my second question is equally important, Dr. Ashwini. Supposing a patient comes to you, has AKI, and has been on SGLT2 inhibitors for a number of years now. what would you do now to the SGLT2 inhibition? Would you stop, temporarily hold them? And if yes, when to restart them? All those things which are very, very pertinent. The way we used to talk in with reference to RAS blockers, and I think in the same breath, I'm going to ask you about SGLT2 inhibitors.
It's again a very practical point. You have to look at the patient's situation. In a critically sick patient, when the blood sugars are fluctuating, then definitely you will look at the insulin as the main treatment, and you will be stopping other oral hypoglycemics like metformin, and even I would say SGLT2 should be omitted in a very sick, critically sick patient in ICU. Otherwise, if patient is not that sick and his creatinine is gradually rising, we should hold it only in those situations when patient is dehydrated, hypovolemic, he has UTI, or there is suspected ketoacidosis or active foot disease. Then I would definitely stop SGLT2. But otherwise, in a very sick patient, you manage diabetes with insulin, I think, and at that time, it should be stopped.
So now moving on to some peculiarities about the management of a given case of AKI. So many times we encounter patients who have already reached a stage of fluid overload during the episode of AKI. Dr. Manjari, this one is for you. On one hand, we are looking at a patient who has volume overload. At the same time, patient is acidotic. You want to give him or her sodium bicarbonate, right? So that's my question number one to you. What is your take on the role of sodium bicarbonate? Do you think if it is required, you should go ahead and use it, or should you be scared about the causation of or aggravation of volume overload should you choose to use sodium bicarbonate? Yeah.
Thank you, sir, again for a very important question. I think sodium bicarbonate is overused. There are people in the ICU, basically it is check the ABJ, and once they find that there is the pH is low, they straight away start with ABJ. So straight away they start with sodium bicarbonate. So by the time you come to see the patient, you'll see that the patient is fluid overloaded. He's having acute pulmonary edema, and you have nothing else to do but put the patient on hemodialysis. So we should be very judicious in using sodium bicarbonate. We should not be judged always by the ABG report. We should, like the panelists are saying, we should make a clinical judgment first. Find out the cause of his renal failure. Find out the other abnormalities that the patient have. Look into his volume status, and then we have to go ahead with replenishing the fluids in these patients. And if the patient is grossly acidotic, obviously you have to put the patient on sodium bicarbonate. If the patient is not improving, it is conservative management, we have to go ahead and do the dialysis in the patient. So we have to first make a clinical judgment before putting the patients on any extra fluid or not putting the patient on fluid. We have to see the patients clinically.
So, as a corollary to this discussion, Dr. Patil has a question for you. Low ejection fraction with CKD. How should we manage such patients, especially as far as their fluid intake planning is concerned? Patient has volume overload, is, as I said, has a HFrEF and existing CKD. So maybe we are referring to cardiorenal syndrome type 2 or maybe type 4 also at the same time. So how would you manage these patients as far as their fluid intake is concerned, and also at the same time the role of diuretics in such a situation?
Yeah, this is a very tricky situation. Many times you get patients with such cardiac involvement where you cannot put the patient much on the fluid, or neither you can deny the patient with some diuretics. So it has to be balanced between a use of the diuretic and the amount of fluid that you give to the patient. We have to look for the signs of fluid overload. We also have to look into the signs whether the patient is making urine or not. So we have to make a balance between the urine output of the patient and the cardiac status of the patient and manage accordingly.
So, Dr. Vishwanath, coming to the reason we are here today, and that's trying to prevent chronic kidney disease. We may be talking about acute kidney injury, but I have repeatedly highlighted the fact that this ongoing webinar discussions are predominantly talking about the management of chronic kidney disease, and today is no exception. But why we chose AKI is, as I said at the outset, that a lot of patients can actually lead on to chronic kidney disease from a stage of AKI. So, what, in your opinion, are the long-term risks of chronic kidney disease after an episode of severe AKI, severe enough to even warrant dialysis? So what is, because you see this is in sharp contrast to our earlier thinking, but well, it can either be temporary, reversible, or it would be chronic. And then over the period of time, we have realized, well, there could actually be a transition, and that's why we have an entity called acute kidney disease. Like if AKI is in the early stages and CKD is beyond 3 months, what happens between these days 7 and 90? So that again, we have coined the term acute kidney disease, and so many times you may find things reversing from that stage or moving on to CKD. How common is such an occurrence?
In fact, all of us have come full circle. Initially, when we were in training, we were all told acute renal failure or AKI will completely recover. But over a period of time, all of us have realized it is not that only all AKIs will recover completely. And many of us would have seen AKI, what we had seen about 10 years back, 15 years back, coming back to us with some amount of CKD underlying component, or any small thing happens after 10-15 years, they're going to be needing dialysis or which may not recover. And this happens even more in people who are at risk of developing these CKD complications after an AKI episode. More common is seen in people with long-standing diabetes or who have an underlying CKD or what we call as poor renal reserve. In fact, many people have looked at doing these studies like protein infusion, plasma estimation of GFR, which would probably give us a better idea whether kidney has recovered fully or not. Definitely, AKI is not so simple and not 100% recoverable. In specific situations, in high risk groups like diabetics, elderly people, vascular problems, people may not recover completely. So that's the reason preventing an AKI is very, very important and pertinent, and preventing with much more aggressive approach will definitely help in going further and developing a CKD.
Well, I think it's just a time coming in between such a lively, fruitful discussion. But and for one, am not wanting to let go of this opportunity of learning more and more from my esteemed colleagues. But then I think at the end of the day, it's what I have to accept that it's time to go. But before that, a quick uh, 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 um, take on a few other very important points. Abhishek. I'm sorry you're not visible today, but then I think in incognito rather, maybe you can address this question posed by Dr. Surinder Gupta. He wants to know whether can we opt for oral antibiotics treatment in acute kidney infection, be it a pyelonephritis with fever, a patient has a full field of pus cells in a otherwise healthy subject, no comorbidities, and is about septuagenarians, is about 70 years old, and would you believe that hospitalization is always a must when you are treating a patient with acute pyelonephritis and AKI? So this is about some kind of basic understanding that how aggressive should we be with any episode of upper UTI, acute pyelonephritis, which had resulted in acute kidney injury. Abhishek, would you want to take that up? Would you want to invariably hospitalize all such patients, or do you want to give a trial with oral antibiotics to such patients?
So, sir, with regards to management of such a case of pyelonephritis, I think it is more the entire clinical picture rather than just the presentation of pyelonephritis. So certainly, a gentleman who has developed pyelonephritis, has high-grade fever, chills, but does not have any other hemodynamic alterations, has good mentation, is taking well orally, is accepting well orally, does not have severe AKI, only if at all, only mild renal dysfunction. I think it is prudent that we give him a trial of oral antibiotics and we treat them with expectant OPD management. However, if this pyelonephritis progresses to sepsis syndrome and there is organ dysfunction in other organs as well, I think that's the time when we should be aggressive and hospitalize and shift to IV antibiotics. The other thing is, yes, with regards to such an age group, I think we have to be more vigilant with regards to the clinical features because not such patients would not be presenting with your fulminant cases, all fulminant manifestations all the time. So we have to be slightly more vigilant with regards to them. But with antibiotics, yes, oral, of course, we can use.
So, well, to share, about 1696 doctors from across the country had logged in today. And the last question is for you, Divya. Dr. Vikas wants to know, is there any difference in the protein intake recommendations as far as the AKI versus CKD is concerned?
Yeah. So we are short of time. So a very crisp, short answer. AKI is a catabolic state. Patients are invariably in protein energy wasting. We should be making sure that we don't make them very net protein negative. So it's a tightrope walk. If you give too much proteins, you might end up with increasing their blood urea nitrogen levels. So what is that sweet spot? People have given tried up to 2.5 gram per kg per day and they have burned their fingers. That's not correct. So what European Society of Clinical Nutrition, ESPN, recommends in 2023 that anyone who has a mild AKI who do not require dialysis, who are not very catabolic, should be getting anywhere around zero point 0.8 to 1 gram per kg per day of protein. If your patient is on intermittent hemodialysis, which is we do 4 hours, thrice a week, that kind of a dialysis, then you should be getting 1 to 1.3 gram per kg per day. If your patient is on CRRT or prolonged intermittent dialysis like SLED, then they should be on 1.5 to 1.8 gram per kg per day. For CKD, recommendations are if they're not on dialysis, it should be 0.8 to 1 gram per kg per day. If they're on dialysis, depending on HD or PD, it should be anywhere from 1 to 1.5 gram per kg per day. It should be a mix of non-essential and essential amino acids. People have tried giving glutamine, but it has not helped.
Oh, thank you very much. Excellent, excellent. And I think I stand corrected. I have a very important news to share. We have crossed all-time high today. There have been 2004 live participants today, which has been an all-time record. Thank you very much for those who have joined us today for reposing your faith in the time spent with us. Thank you very much. That's very encouraging, and I think speaks volumes of the kind of expert panel we had today to involve instill so much of confidence in everyone to join us today. Thank you very much. We will certainly try to do better with each subsequent episode. It's my pleasant duty to once again profusely thank everyone who has been part of today's discussion, starting from Dr. Abhishek, who did a fantastic job with his excellent presentation, followed by I couldn't have thought of better panelists than what we got today for this very nice subject. So my sincere thanks to INTAS, spearheaded by Mr. Amit Arora, ably assisted by Dr. Mithilesh and Mr. Gaurav Khanna. Gaurav could not make it today. He's traveling today, but these are the people behind the show. Dr. Mithilesh does a fantastic job with coming out with the relevant information and the discussion points we incorporate for our meetings on a regular basis. But certainly all credit goes to the leadership of Mr. Amit Arora. And I would want to remind one more time to all those who have joined, it's a purely academic exercise, as you would have not seen any branding anywhere. And that has been the promise which Mr. Amit Arora has made, and certainly it speaks volumes of their commitment towards spreading knowledge across our country and even in the neighboring countries as well. Thank you very much, and over to you, Dr. Mithilesh, for the concluding remarks. Yeah.
Yeah, thank you, sir. So I am honored to deliver the vote of thanks. First, a heartfelt thanks to our esteemed speaker, Dr. Abhishek, Dr. Ashwini Gupta, Dr. Vishwanath, Dr. Manjuri Sharma, and Dr. Divya Bajpai for sharing their expertise and practical insight on managing AKI. A special thanks to our co-director, Dr. Dinesh Kullar sir, whose leadership made this session very possible and very interesting. We also appreciate our wonderful audience, nearly 2,200 participants, for their enthusiasm and engagement. Lastly, a big thank you to our tech support team for ensuring smooth experience. We are truly value your support and look forward to seeing you again in future sessions. So with this, good night and thank you everyone.
Thank you very much once again, everyone. Thank you very much and have a good night. Sorry to have overstepped on your
Good night.
times,
Good
but
night.
then I think
Thank
I
you.
was thoroughly enjoying the discussion, the flow of events, so I couldn't resist myself and could say a no at the right time. Thank you very much.
Thank you, Dinesh.
See you next month.
Good night.
Thank you, everyone. Good night to all.
Thank you. Good night.